Hi everyone, good day. This is Doc Von, and for this week, we will be discussing about your parathyroid gland. So for our learning objective for the parathyroid discussion, we will be reviewing again the anatomy and histology of your parathyroid gland, then discuss the regulation and function of your parathyroid hormone, and lastly, correlate the laboratory methods and the different clinical diagnosis or clinical disorders relating to your parathyroid gland. For the anatomy and histology, your parathyroid gland is located posteriorly to your thyroid gland. So this view is actually in posterior view. So this is at the back of your neck. So remember this green organ, this is actually your thyroid gland, and that yellow dot here are actually your parathyroid glands. So your parathyroid glands are usually located on the posterior aspect of your thyroid gland. They are actually flattened and in oval shape, situated external to the thyroid gland itself but within your pretracheal fascia. Most individuals have actually 4 parathyroid glands, although variation in numbers may also occur. Some will have 2 or even 6. In terms of its blood supply, your superior parathyroid gland is supplied by your superior thyroid artery, because remember, it is just located within your thyroid gland. So the blood supply also comes from your thyroid gland. Again, your superior parathyroid gland, the blood supply of it will be from your superior thyroid artery, while your inferior parathyroid gland, the blood supply is from your inferior thyroid artery. For the histology of your parathyroid gland, remember this tissue? This is actually your thyroid gland. That circular part there is actually your follicles and with your colloid inside. Then this structure here, or this tissue, is actually your parathyroid gland. Let's take a look. So this is the bigger picture of your parathyroid gland tissue. It is actually comprised of 2 cells. We have your chief cells and your oxyphil cells. Your chief cells is actually responsible for the production of your parathyroid hormone, while your oxyphil cells is actually responsible for the production of your PTHrP, or your parathyroid hormone related protein. Some book will say that your oxyphil cells have no definite function, but some books will say that it is related to your chief cells in terms of its gene, and because of that, it may produce your PTHrP, or your parathyroid hormone related protein. But basically, your chief cells produces your PTH, while your oxyphil, the function is still unknown, but some book will say produces your parathyroid hormone related protein. Later on, we will see what is the significance of your PTHrP. Now let's proceed with the parathyroid hormone itself. Again, it is secreted by your chief cells, which is responsible to rapid response to reduced calcium. So it will respond immediately when there is a low serum calcium, because what is the main function of your parathyroid hormone is to increase your calcium. Is to increase your serum calcium. So that's basically the function of your parathyroid hormone. It is actually a polypeptide, approximately 84 amino acid residues, 9,500 Dalton. So your parathyroid hormone operates in tissues via your COMP2 messenger. Remember that your parathyroid hormone uses a secondary messenger to have an effect, and it is your COMP2 messenger. So the net effects of your parathyroid hormone again is to increase your total or your ionized calcium. So the negative feedback for your parathyroid hormone is to lower your parathyroid hormone secretion. Again, the main effect or the total effect of your parathyroid hormone is to increase your total serum or ionized serum calcium in the blood. Now let's talk about the regulation of your parathyroid hormone. So it happens in your parathyroid cell. Your calcium binds to a receptor, to a calcium sensing receptor, coupled to a G protein, which will yield to the activation of your phospholipase C. Again, so you have your calcium. Your calcium will bind to your receptor. Anong tawag sa receptor na yon? Calcium sensing receptor. Once your calcium binds to your receptor, it will be coupled to a G protein. Then this complex will cause the activation of your phospholipase C. So later on, we will have a nice diagram to explain these words. So the regulation of your parathyroid hormone, remember your phospholipase C, it will now convert your phosphoinositides into IP3 and your diacylglycerol. Your IP3 or your inositol triphosphate releases your calcium from the internal stores, while your DAG will stimulate your protein kinase C activation, and this protein kinase C will inhibit your parathyroid hormone release and synthesis. Again, ulitin natin ha, your calcium will bind to a receptor, then it will be coupled to a G protein, then it will activate to your phospholipase C. Your phospholipase C will have two effects. It will be converted into will convert your phosphoinositides into your IP3 and your DAG. Your IP3 will have its own effect. It will release your calcium from the internal stores, and your DAG, on the other hand, will stimulate your protein kinase C. Your protein kinase C will inhibit the release of your parathyroid hormone and its synthesis. So this diagram will explain the previous statements. Let's see. If you have an increased serum calcium, what will be the negative feedback of the body? So if you have already an increased level of your calcium, the negative feedback is actually to decrease your calcium, to decrease the calcium itself, because you already have too much level of your calcium. So an increased serum calcium, pag maraming calcium, ano nangyayari? Your calcium will bind here. This is your calcium sensor receptor. So now this is your receptor. Your calcium will bind here to your calcium sensor coupled with your G protein. Then this complex will yield to the stimulation of your phospholipase C. Your phospholipase C will now cause a negative feedback or inhibition of your parathyroid hormone. You will inhibit the secretion of your parathyroid hormone. Again, when you have too much serum calcium, your calcium will bind to the receptor, which is called your calcium sensor receptor, and this will be coupled to your G protein. This complex will stimulate your phospholipase C to inhibit the secretion of your parathyroid hormone, because you have already enough serum calcium and you do not need excess calcium in your blood. The question, what will happen if we have low level of calcium in the blood? A low level of your calcium in the blood will result into no attachment of your calcium sensor, meaning walang mag-a-attach na calcium dito kasi nga low ang calcium mo. So what will be the effect? You will now have an inactive sensor. An inactive sensor, which is a sensor without calcium, will cause no inhibition of your parathyroid hormone secretion. In short, kasi nga walang calcium naka-attach dito, ang calcium sensor nagiging inactive. Because of that, it will result into the stimulation of your parathyroid hormone. In short, your parathyroid hormone will be synthesized or secreted to the blood. Again, calcium sensor, once activated, it will result into the inhibition of your parathyroid hormone. Calcium sensor inactivation will result into the suppression of your parathyroid hormone. So in short, baliktad guys. Pag naka-activate ang calcium sensor, ini-inhibit ang parathyroid hormone. Pag walang naka-attach sa calcium sensor, it is an inactive sensor, meaning magsisecrete ng parathyroid hormone. So in short, if for example here, walang calcium na naka-attach dito, masisecrete yung parathyroid hormone, and it will go to its target tissue. So what are the target tissue of your parathyroid hormone? It is your kidney and bone. In the kidney, it will result into increased absorption, increased secretion of your vitamin D, increased calcium reabsorption. In the bone will yield to increased calcium resorption. So the net effect of your parathyroid hormone is actually to increase your serum calcium. I guess that's very clear. Now let's proceed with the functions of your parathyroid hormone. Again, sa bone, anong effect sa bone ng parathyroid hormone? Your osteoblast stimulation to produce your RANKL. Ano to RANKL? Is actually your receptor activator of nuclear factor Kb ligand. So it's a ligand which will activate your RANK in your osteoblast. So the end point will be increased bone resorption and increased calcium, which possesses a risk to the patient, yielding to an osteoporotic bone. Because kasi nga ano nangyayari? There will be osteoclastic activity. Nawawalan ng calcium ang ating bone patungo sa ating dugo kasi nga we want to increase the level of your serum calcium. Again, sa bone, it will stimulate your osteoblast stimulation, will produce RANKL ligand, which will activate your RANKN, which will cause a osteoclastic activity. The net effect is to cause bone resorption, thereby increasing your calcium. Tingnan natin dito. When your parathyroid hormone is being stimulated, your PTH will be released to the blood and will have a target tissue in your bone. In your bone, your PTH stimulates osteoclastic activity. Bone is resorbed, which releases calcium into your bloodstream. In short, the net effect of the bone is to increase your serum calcium. How about in the kidney, doc? In the kidney, your parathyroid hormone increases your urine excretion of your phosphate, causes calcium reabsorption in the nephron, and your vitamin D activation. In short, sa kidney, may tatlong effect ang parathyroid hormone. Pinapataas ang excretion ng phosphate, ini-increase ang absorption ng calcium, ini-increase ang activation ng ating vitamin D para mas maraming calcium na marireabsorb. So, tatlong effect. Increase your urine excretion of your phosphate, calcium reabsorption, and your vitamin D activation. In short, ang parathyroid hormone hindi lang nag-i-increase ng ating serum calcium, but also it decreases your serum phosphate kasi nga pinapataas niya ang excretion ng ating phosphate sa ating ihi. So the net effect would be decreased serum phosphate. So again, review natin ha, ano nang effect ng ating parathyroid hormone? The net effect of our parathyroid hormone is to increase your serum calcium and decrease your serum phosphate. Kasi nga, sa kidney, ang function ng parathyroid is to increase your urine excretion of phosphate, calcium reabsorption in the nephron, and your vitamin D activation. I guess paulit-ulit, inuulit na lang natin para at least mas ma-recall ang ating mga discussion. Now, let's proceed with our laboratory methods. I guess guys, this is gonna be a very short discussion lamang. So, for the laboratory methods, we will be measuring the intact parathyroid hormone. So, how do we measure that? Using two antibodies against your N-terminal and your C-terminal using your ELISA. Your intact parathyroid hormone is actually the one that is biologically active form. However, the half-life of your intact parathyroid hormone is only less than 4 minutes. And your kidney and as well as your liver will clear the intact parathyroid hormone rapidly in the liver and it will be cleaved into different fragments. And these smaller peptides are actually released into the circulation. Again, what is being measured is your intact parathyroid hormone. However, it has only a shorter half-life, which is approximately 4 minutes. And this intact parathyroid hormone will be cleared by your liver and kidney into smaller fragments, which will be released into the circulation. How about your parathyroid-related peptide? Again, we already discussed your parathyroid hormone-related peptide. Remember that your Some books or textbook would say that your eosinophil cells will produce your parathyroid hormone-related peptide. And it is actually produced by certain tumors. When you have your lung carcinoma, breast carcinoma, kidney carcinoma, and other solid tissues. So, sometimes we see na ang patient namin may patients kami na may breast, we see that sobrang taas ng kanyang serum calcium. And it's actually related to your PTH related peptide. Kasi nga, your PTH related peptide has the same PTH receptor and function. And what is the function? To increase your serum calcium. That is why your PTH-RP is very related to tumors. It has actually approximately 141 amino acid, shares the same homology with your parathyroid hormone in the first 13 amino acids. It is present in patients with malignancy-associated hypercalcemia. So, this PTH-RP is related to your malignancy. So, remember this one. Let's proceed with the different diseases related to your parathyroid hormone or your calcium homeostasis. Let's talk about your hypercalcemia. When we say hypercalcemia, this is increase in your serum calcium. What are the common causes of your hypercalcemia? We have your hyperparathyroidism, malignancy associated with your PTH-RP, vitamin D intoxication, hypercalcemia in granulomatous disorders. We have also your, milk alkali syndrome or your Burnett syndrome. Let's talk about your primary hyperparathyroidism. When we say primary, ano ang ibig sabihin yan? The organ that produces the hormone has the problem. Since it is hyperparathyroidism, so the problem is within your parathyroid gland. It is a excessive secretion of your PTH with no stimulus or no response to negative feedback mechanism. Since you have increased secretion of your PTH, diba, your body will try to compensate it through a negative feedback mechanism. But since it is a primary hyperparathyroidism, it will not be no stimulus or no response to a certain feedback mechanism. It is caused by a parathyroid adenoma, hyperplasia, as well as your carcinoma. Again, primary hyperparathyroidism, increased calcium. And these patients who have primary hyperparathyroidism, those who have adenoma, hyperplasia, carcinoma, will have higher risk of heart problem, atherosclerosis, osteoporosis, as well as your kidney stone. Why? Because your calcium may be lodged or may be stored in your coronary arteries or into your blood vessels, yielding into atherosclerotic blood vessel or osteoporosis. Why do you think osteoporosis? Remember the function of your parathyroid hormone? Your parathyroid hormone will cause increased osteoclastic activity, wherein the calcium will be released from the bone into the bloodstream, increasing serum calcium but decreasing the calcium into their bone. That's why patient may be at a higher risk of osteoporosis. Why kidney stone? Because your calcium may be stored also within your kidneys and may form into kidney stones. Your primary hyperparathyroidism can also be a hereditary in nature. This may be caused by endocrine carcinoma, specifically your multiple endocrine neoplasia type 1 or multiple endocrine neoplasia type 2A. This is actually a endocrine tumor, a complex endocrine tumor, because this is a combination with other carcinoma of the body. For example, we have your multiple endocrine neoplasia type 1. It is a correlation, an endocrine cancer with endocrine cancer that is related to parathyroid, pituitary, and pancreas. Ang ibig sabihin niyan, meron kang parathyroid carcinoma, you have a pituitary carcinoma, and you have also a pancreatic carcinoma. In short, this is a complex type of cancer. Kaya nga tinawag natin na multiple neoplasia, endocrine neoplasia, something to do with your endocrine glands. So, for your men type 1, related to your parathyroid, pituitary, and your pancreas. How about your men type 2, your multiple endocrine neoplasia type 2A? It is correlated with your thyroid cancer, your pheochromocytoma. Ano nga to? This is related to your adrenal gland and your hyperparathyroidism, which is related to your parathyroid gland. So in your MEN 2A, it is a combination of your thyroid gland, your adrenal gland, and your parathyroid gland. So sa type 1A and type 2A, they have a similar carcinoma in your parathyroid gland. Parathyroid gland. But they differ on two different gland, which is your pituitary and pancreas sa type 1, thyroid and adrenal sa type 2A. So I guess this is very complex na, but I just want you to remember that these hereditary factors or hereditary carcinoma is also related to a primary hyperparathyroidism. Therefore, our patient will have increased serum calcium. Ano ngang hormone ang related pag sinabing carcinoma? It is your PTHrP. So let's proceed with the other causes of hypercalcemia. We have your vitamin D intoxication. Your vitamin D intoxication will cause an increased calcium absorption in the intestine and increase also your bone resorption. We have also hypercalcemia in your granulomatous disorders, common in patients with sarcoidosis. So what is this sarcoidosis? Basically, your sarcoidosis is a inflammatory disorder that affects multiple organs in the body. But the most common organ that is being affected by this sarcoidosis is actually your lungs and your, your lungs and your, I forgot, most common is lungs, and basta remember, sarcoidosis is most common in the lungs, and I forgot the other organ system. But basically, patient will have a severe respiratory distress kasi nga they have this inflammation within your lung parenchyma. This is brought about, the hypercalcemia in your granulomatous disease is brought about by unregulated generation of your vitamin D. So in short, you are producing increased amount of your vitamin D. So this increased amount of your vitamin D can lead into hypercalcemia. We have other causes of your hypercalcemia. We have your milk alkali syndrome. This is common to the patient who have peptic ulcer disease or those who have increased calcium absorption or absorbable alkali, or those taking with calcium carbonate. Remember, this calcium carbonate is very rampant nowadays because of some patients will take this as a prophylaxis for your osteoporosis, and taking too much of your calcium carbonate or your antacids from your peptic ulcer disease will cause your milk alkali syndrome. And this syndrome can be a manifestation of hypercalcemia, hypocalciuria. There could also be alkalosis, azotemia, as well as your soft tissue calcification. So now let's proceed with hypocalcemia, which is a decreased level of your serum calcium. Your hypocalcemia can be caused by decreased parathyroid hormone production or secretion, or resistance to parathyroid hormone action, wherein you have a normal level of your parathyroid hormone. However, our body failed to respond to the parathyroid hormone itself. We also have a deficiency of your vitamin D. Let's proceed with your hypoparathyroidism. This is brought about by a diminished or absent parathyroid hormone production. This can be divided into two, can be acquired or inherited. Pag sinabi na acquired, this is brought about by neck surgery or thyroidectomy. Remember your thyroidectomy, the removal of your thyroid. It could be partial or total. Pag sinabi natin total, the entire thyroid gland is being removed. So doc, bakit po tayo nagkakaroon ng hypoparathyroidism? Remember, your parathyroid gland is situated posterior to your thyroid gland. So there is a big chance that your parathyroid gland can also be transected or can be damaged during the procedure. That is why patient may take calcium supplements after your thyroidectomy. We also have your inherited type of your hypoparathyroidism, defective thymus and parathyroid gland. This is associated with your DiGeorge syndrome. So I have a mnemonics here. When we say DiGeorge syndrome, ang tatandaan nyo lang is the mnemonic catch-22. Ito talaga yung nare-remember namin pag narinig namin ang salitang DiGeorge syndrome. Your catch-22. Anong ibig sabihin ng catch-22, doc? Your DiGeorge syndrome is actually a combination of, first, letter C, cardiac anomaly. Patient may manifest with cardiac problem or murmur. A. A stands for abnormal facial feature, or there is abnormal fascia. T stands for thymic hypoplasia, meaning the patient have hypoplastic thymus. So in short, if patient have a hypoplastic thymus, there will be poor differentiation of your T cells. Remember that your T cells are differentiated in your thymus gland. So without your T cells, what will happen, or what will be the manifestation of our patient? Our patient may have severe infection or recurrent infection. C stands for patient may have cleft palate. And lastly, H stands for hypocalcemia because of defective parathyroid gland. Ano po itong 22, Doc? Because this is inherited, the chromosome 22 is actually affected. So catch 22. Again, patient will have cardiac problem, abnormal facial feature, thymic hypoplasia, that's why patient may have recurrent infection. C, patient will have cleft palate. And lastly, H, patient may have hypocalcemia. And the 22, chromosome 22 is affected. Hereditary autoimmune syndrome or autoimmune polyglandular deficiency is also an example of your hypoparathyroidism that is inherited. So this is now our DiGeorge syndrome. Again, DiGeorge syndrome. Ano nga yun? Catch-22. Ulit-ulitin natin ha. Catch-22. Cardiac problem or cardiac anomaly. A, they have abnormal facial feature or abnormal fascia. Ano yung abnormal fascia na yan, Doc? Hooded eyes, relatively long face, small and low set ears. So that's your abnormal fascia. T, thymic hypoplasia. That's why patient is very prone to infection. They will have a recurrent infection. Letter C. Anong letter C? They have cleft palate. That's what you can see. And H, since they have a defective parathyroid gland, there will be hypocalcemia. And 22, or also known as your 22q11.2 deletion syndrome, which is a syndrome caused by the deletion of a small fragment of chromosome in your chromosome 22. So that is your DiGeorge syndrome. These are common in young individuals who have recurrent infection. Last, we have also your pseudohypothyroidism, or aka your Albright hereditary osteodystrophy. It is a genetic disorder where the body fails to respond to the parathyroid hormone. So in short, this is now your parathyroid hormone resistancy. Kasi nga, tinawag natin pseudo kasi nga, meron tayong parathyroid hormone. But the body do not respond to your PTH. There is parathyroid hormone resistancy. And they can be manifested with low blood volume calcium and high phosphate level. So the characteristic could be short height, short hand bones, bone below the fourth finger. So I guess it's a very short discussion lang kasi nga we will repeat again this discussion when we reach the calcium homeostasis topic sa ating clinical chemistry na laboratory part. So at that discussion, we will now correlate your parathyroid hormone, your calcitonin, and your vitamin D because these three hormones has something to do with your calcium homeostasis. But in this discussion, I just want you to focus more into your parathyroid gland because it's again a repetition lang naman when we reach that discussion of your calcium homeostasis. So that ends. So thank you everyone. If you have any question, you can PM me anytime. Thank you everyone. God bless and mabuhay.